Hello, my name is Fiona May Tweddle, and the Group 5 will be presenting our topic on feces and sweat. So the members of our group include Miss Bunyi, Miss Disco, Miss Halyarina, Miss Manantan, Miss Ragupos, and myself. So allow me to introduce the topic outline for our discussion today. Excuse me. We have our introduction to fecal analysis. Next, our physiology and formation of feces. Then our disorders of gastrointestinal tract, macroscopic screening, microscopic examination, introduction to sweat analysis, physiology and composition of sweat, sweat disorders, and sweat analysis tests. Next slide po. Next, we have our learning objectives. At the end of the discussion, students should be able to describe the normal composition and formation of feces, differentiate malabsorption from maldigestion syndrome, and name a test that distinguishes the two conditions. We should be able to instruct patients in the proper collection of random and quantitative stool specimens, describe and interpret the macroscopic characteristics of stool, describe and interpret the microscopic results of stool specimen, explain the methods used to detect fecal occult blood, briefly describe a chemical screening test performed on feces for each of the following: the fetal hemoglobin, pancreatic insufficiency, and carbohydrate intolerance. Next, describe the normal composition and formation of sweat, identify and discuss disorders associated with sweat, and lastly, we should be able to describe the tests performed for sweat analysis and be able to interpret the results. So now let us begin our discussion with our introduction to fecal analysis. So this chapter outlines the routine clinical examination of feces and the valuable insights it provides to healthcare professionals. Of course, to our healthcare professionals, they'd much rather prefer testing our specimens, our most common specimens, which are blood and urine. However, assessing fecal matter is essential for identifying certain medical disorders. These include our gastrointestinal disorders, infections, and the like. Routine analyses include our macroscopic, microscopic, and chemical testing, which are conducted in the central laboratory to identify conditions such as our colon cancer, steatorrhea, and other malabsorptive or maldigestion disorders. Furthermore, the microbiology department also conducts specific tests for stool pathogens, which include our bacteria, viruses, and parasitic agents, along with their respective toxins. Now, let us discuss how feces are actually formed in the body. And we know that feces are formed from our digestive system. So, our digestive system is composed of the alimentary canal, which is a continuous tube from our mouth to the anus and includes the esophagus, the stomach, the intestines, the colon, and our accessory digestive organs, including the mouth, pharynx, the teeth, tongue, salivary glands, liver, gallbladder, and pancreas. The gastrointestinal tract contains and processes food from ingestion, which is from our mouth, then through digestion, which takes place. Well, mechanical digestion actually takes place in the mouth as well. Then chemical digestion takes place in the small intestine, and elimination from the large intestine via the anus. So our food and water ingested becomes chyme in the stomach and small intestine. So what is the chyme? It's a mixture of the digestive secretions, such as our hydrochloric acid, with our partially digested food. Enzymes are also part of the chyme. They start with salivary amylase in our mouth and include also the stomach enzymes and many pancreatic enzymes, which are added along to the food in the pathway. After chyme has remained in the large intestine for 3 to 10 hours, it normally becomes solid or semi-solid and then is called our feces. Although digestion of ingested proteins, carbohydrates, and fats takes place throughout the entire alimentary tract, the small intestine is actually the primary site for the primary breakdown and reabsorption of these compounds. And where in the small intestine are these compounds reabsorbed? They are absorbed in the microvilli, which are found on the villi of the uh, small intestine. Excuse me. So our digestive enzymes secreted into the small intestine by the pancreas include trypsin, chymotrypsin, aminopeptidase, and lipase. Bile salts are also provided by the liver, aid the digestion of fats. A deficiency in any of these substances creates an inability to digest and then therefore reabsorb certain foods. And excess undigested or unabsorbed materials then appear in the feces, and the patient exhibits symptoms of maldigestion and malabsorption. Along the way, much of the water, nutrients, and vitamins, as well as electrolytes, are absorbed into the circulatory system. Despite about 9 liters of water entering the small intestine from ingestion and digestive foods, only about 0.1 liters of water is excreted in feces daily, as most is absorbed via osmosis in small intestines, with only about 1/10 of the volume. 0.9 is also being absorbed in the large intestine. Approximately 9,000 milliliters of ingested fluid, saliva, gastric, liver, pancreatic, and intestinal secretions enter the digestive tract every day. Under normal conditions, only between 500 to 1,500 ml of this fluid reaches the large intestine, and only about 150 ml is excreted in the feces. As you can see, the majority of the water that we intake is reabsorbed back to the body, and only little is excreted in the feces. So the normal fecal system should contain bacteria, cellulose, undigested food, GI secretions, biopigments, cells from the intestinal walls through cell slowing, electrolytes, and water. Approximately 100 to 200 grams of feces is excreted in a 24-hour period. Many species of bacteria make up the normal flora of the intestines. Bacterial metabolism produces a strong odor associated with feces and intestinal gas, otherwise known as flatus. Carbohydrates, especially oligosaccharides that are resistant to digestion, pass through the upper intestine unchanged but are metabolized in the lower intestine, producing large amounts of flatus. And this excessive gas production also occurs in lactose intolerant people when the intestinal bacteria metabolize the lactose from consumed milk or lactose containing substances, because lactose intolerant people do not have the enzyme lactase, which is needed to break down lactose that is present in milk. Let me just summarize the image, just a short summary of the physiology. So we start ingestion of food, which happens in the mouth. That's mechanical digestion, and then it moves down the esophagus and into the stomach, where chemical digestion takes place, forming chyme, which consists of our hydrochloric acid and enzymes from pancreatic secretions. After this chemical digestion, the chyme travels down the small intestine, where it is further broken down with more enzymes and further. This is the main site of reabsorption into the blood. And again, how are they reabsorbed? By the microvilli. And any undigested foods travel down to the large intestine, where again also more water is reabsorbed. And then lastly, the feces or the undigested foods are excreted as feces by the anus. And next we will have our discussion on the disorders of gastrointestinal tract.
Disorders of the gastrointestinal tract. Diarrhea. Diarrhea is defined as an increase in daily stool weight above 200 grams, increased liquidity of stools, and frequency of more than 3 times per day. Diarrhea classification can be based on 4 factors: illness duration, mechanism, severity, and stool characteristics. Diarrhea lasting less than 4 weeks is defined as acute, and diarrhea persisting for more than 4 weeks is termed chronic diarrhea. Secretory diarrhea. Secretory diarrhea is caused by increased secretion of water. Bacterial, viral, and protozoan infections produce increased secretion of water and electrolytes, which override the reabsorptive ability of the large intestine, leading to secretory diarrhea. Enterotoxin-producing organisms such as Escherichia coli, Clostridium, Vibrio cholerae, Salmonella, Shigella, Staphylococcus, Campylobacter, protozoa, and parasites such as Cryptosporidium can stimulate these water and electrolyte secretions. Other causes of secretory diarrhea are drugs, stimulant laxatives, hormones, inflammatory bowel disease, Crohn's disease, ulcerative colitis, lymphocytic colitis, diverticulitis, endocrine disorders such as hypothyroidism, Zollinger-Ellison syndrome, lipoma, neoplasms, and collagen vascular disease. Next, osmotic diarrhea. Osmotic diarrhea is caused by absorption that exerts osmotic pressure across the intestinal mucosa. Incomplete breakdown or reabsorption of food presents increase fecal material to the large intestine, resulting in water and electrolyte retention in the large intestine, which in turn results in excessive watery stool. Maldigestion or impaired food digestion and malabsorption or impaired nutrient absorption by the intestines contribute to osmotic diarrhea. Next, altered motility. Altered motility describes conditions of enhanced motility or slow motility or constipation. Both can be seen in IBS or irritable bowel syndrome, a functional disorder in which the nerves and muscles of the bowel are extra sensitive, causing cramping, bloating, flatus, diarrhea, and constipation. IBS can be triggered by food, chemicals, emotional stress, and exercise. Intestinal hypermobility is the excessive movement of the intestinal contents through the GI tract that can cause diarrhea because normal absorption of intestinal contents and nutrients cannot occur. It can be caused by enteritis, the use of parasympathetic drugs, or with complications of malabsorption. Rapid gastric emptying or RGE, dumping syndrome, describes hypermotility of the stomach and the shortened gastric emptying half-time, which causes the small intestine to fill up too quickly with undigested food from the stomach. It is the hallmark of early dumping syndrome. Healthy people have a gastric emptying half-time range of 35 to 100 minutes, which varies with age and gender. A gastric emptying time of less than 35 minutes is considered RGE. RGE can be caused by disturbances in the gastric reservoir or in the transporting function. Hypoglycemia is often a complication of dumping syndrome. The main causes of dumping syndrome include Ellison syndrome, duodenal ulcer disease, and diabetes mellitus. Next, steatorrhea. Detection of steatorrhea or fecal fat is useful in diagnosing pancreatic insufficiency and small bowel disorders that cause malabsorption. Absence of bile salts that assist pancreatic lipase in the breakdown and subsequent reabsorption of dietary fat or primarily triglycerides produces an increase in stool fat that exceeds 6 grams per day. Likewise, pancreatic disorders including cystic fibrosis, chronic pancreatitis, and carcinoma that decrease the production of pancreatic enzymes are also associated with steatorrhea. Next, macroscopic screening. The first indication of GI disturbances that can often be changes in the brown color and formed consistency of the normal stool. Of course, the appearance of abnormal fecal color may also be caused by ingestion of highly pigmented foods and medications. So a differentiation must be made between these and a possible pathologic cause. Color. The brown color of feces results from intestinal oxidation of stercobilinogen to urobilin. Conjugated bilirubin formed in the degradation of hemoglobin passes through the bile duct to the small intestine, where intestinal bacteria convert it to urobilinogen and stercobilinogen. Therefore, stools that appear pale or alcoholic stools may signify a blockage of the bile duct. Pale stools are also associated with diagnostic procedures that use barium sulfate. A primary concern is the presence of blood in a stool specimen. Depending on the area of the intestinal tract from which the bleeding occurs, the color can range from bright red to dark red to black. Blood from the upper tract may take about 3 days to appear in the stool, resulting in black tarry stools due to hemoglobin degradation. In contrast, blood from the lower GI tract appears more quickly and retains its red color. Both black and red stools should be chemically tested for the presence of blood because ingestion of iron, charcoal, or bismuth often produces a black stool, and some medications and some foods, including beets, produce a red stool. Green stool may be observed in patients taking oral antibiotics because of the oxidation of fecal bilirubin to biliverdin. Ingestion of increased amounts of green vegetables or food coloring also produces green stools. Appearance. Besides variations in color, additional abnormalities may be observed during macroscopic examination. This table lists common abnormalities seen in macroscopic evaluation. The possible cause of a black color of stool may be due to upper GI bleeding, iron therapy, charcoal, or bismuth or antacids. The possible cause of red color of stool may be due to lower GI bleeding, beets and food coloring, or revamping. The possible cause for the appearance of pale yellow, white or gray stool may be due to bile duct obstruction, barium sulfate, The possible cause of green stool may be due to biliverdin or oral antibiotics or green vegetables. A possible cause for bulky or frothy appearance of stool may be due to bile duct obstruction or pancreatic disorders. And the possible cause of ribbon-like appearance of stool may be due to intestinal constriction. Next, the possible cause for mucus or blood-streaked mucus appearance in stool may be due to colitis, dysentery, malignancy, or constipation. So, pale stools associated with biliary obstruction and steatorrhea appear bulky and frothy and frequently have a foul odor. Stools may appear greasy and may float. The presence of mucus-coated stools indicates intestinal inflammation or irritation. Mucus-coated stools may be caused by pathologic colitis, Crohn's disease, colon tumors, or excessive straining during elimination. Blood-streaked mucus suggests damage to the intestinal walls, possibly caused by bacterial or amoebic dysentery or malignancy. The presence of mucus should be reported. Next.
So let's proceed with microscopic examination. Microscopic examination of fecal smears is used to detect the presence of leukocytes, which are related with microbial diarrhea as well as undigested muscle fibers and lipids. which are associated with steatohera. So the first one, fecal leukocytes. The presence of leukocytes, primarily neutrophils, are seen in the feces in conditions that affect the intestinal mucosa, such as ulcerative colitis and bacterial dysentery. Microscopic screening is performed as a preliminary test to determine whether diarrhea is being caused by invasive bacterial pathogens including Salmonella, Shigella, Campylobacter, Yersinia, and enteroinvasive E. coli. Bacteria that cause diarrhea by toxin production such as Staphylococcus aureus and Vibrio species, viruses, and parasites, usually do not cause the appearance of fecal leukocytes. So therefore, the presence of or absence of fecal neutrophils can provide the physician with diagnostic information before receiving the culture report. Next is the muscle fibers. Microscopic examination of the feces for undigested striated muscle fibers can be helpful in diagnosing and monitoring patients with pancreatic insufficiency, such as in cases of cystic fibrosis. It is frequently ordered in conjunction with microscopic examinations for fecal fats. Increased amounts of striated fibers may also be seen in biliary obstruction and gastrocolic fistulas. So, as you can see, these slides for muscle fiber detection are prepared by emulsifying a small amount of stool in 10% alcoholic eosin, which enhances the muscle fiber striations. The entire slide is examined for exactly 5 minutes, and the number of red stained fibers with well-preserved striations is counted. To accurately identify the types of fibers in stool samples, it is crucial to understand their appearances. Undigested fibers have clear vertical and horizontal striations. Partially digested fibers show striations in one direction, and digested fibers lack visible striations. Only undigested fibers count with over 10 indicating increased presence. Patients are recommended to eat red meat before sample collection for a representative test. So, timely examination within 24 hours ensures accurate analysis, aiding in diagnosing digestive problems by evaluating fiber digestion efficiency. Qualitative fecal fats are performed microscopically for triglycerides or the neutral fats, fatty acid salts or soaps, the fatty acids, and cholesterol. These fats can be stained with Sudan 3, Sudan 4, and oil red O.
So let's go for the chemical testing of feces. The first one is the cold blood. The most frequently performed fecal analysis is the detection of occult blood or the hidden blood. Testing for occult blood has a high positive predictive value for detecting colorectal cancer in the early stage that is recommended by the American Cancer Society, particularly for people older than age 50. Here are the methods for detecting fecal occult blood. The first one is the guaiac, immunochemical and fluorometric porphyrin quantification test. Immunochemical test and fecal porphyrin quantification tests are more sensitive and specific methods than the guaiac-based fecal occult blood test. The guaiac-based fecal occult blood test most frequently of hemoglobin. This is the same principle as the reagent strip test for urinary blood but uses a different indicator, chromogen. The reaction uses the pseudoperoxidase activity of hemoglobin reacting with hydrogen peroxidase, a colorless compound to a colored compound. The next one, immunochemical fecal occult blood test. Immunochemical fecal occult blood test is specific for the globin portion of human hemoglobin and uses polyclonal anti-human hemoglobin antibodies. Because this method is specific for human blood in feces, it does not require dietary or drug restrictions. It is more sensitive to lower. It could be an indicator of colon cancer or other GI disease and can be used for patients who are taking aspirin and other inflammatory medications. The one is the porphyrin-based fecal occult blood test. Hemoquant fluorometric test for hemoglobin based on the conversion of heme to fluorescence hemoglobin. The test measures both intact hemoglobin and the hemoglobin that has been converted to porphyrins. As hemoglobin progresses through the intestinal tract, bacterial actions degrade it to porphyrin that the guaiac fecal blood test cannot detect, thereby making the hemoquant test more sensitive to upper GI bleeding. False negative result from upper gastrointestinal bleeding can be seen with the GFOBT. The porphyrin-based test is not affected by the presence of reducing or oxidizing substances or the water content of the fecal specimen. False positive result can occur with porphyrin-based tests when non-human sources of blood red meat are present. Therefore, patients should be instructed to avoid red meat for 3 days before the test. Quantitative fecal fat testing. Quantitative fecal fat analysis is used as a confirmatory test for steatorrhea. Generally, this is performed in the chemistry department and it is often a reference test. This requires the collection of at least a 3-day specimen. The patient must maintain a regulate intake of fat, 100 grams per decil. Before or during the collection period, refrigerating the specimen prevents any bacterial degradation. The method routinely used for fecal fat measurement. The Van de Kamer titration near infrared reflectance spectroscopy. The nuclear magnetic resonance spectroscopy methods are available. So this is the summary of tests and current instrumentation for fecal fat analysis. The procedure: Sudan 3 materials instrumentation used: Sudan stain microscopy, stereotochrate and acid stereotochrate, material instrumentation, hematocrit centrifuge gravimetric assay. For fecal elastase 1 immunoassay ELISA technique. Near infrared reflectance spectroscopy, NIR spectrophotometry with specialized computer software. Van de Kamer titration, fecal fat extraction, and titration of long-chain fatty acid by sodium hydroxide. For the nuclear magnetic resonance spectroscopy, microwave the dried specimen, hydrogen nuclear magnetic spectrophotometer. Let's go for the APT test or the fetal hemoglobin. Grossly bloody stools and vomitus are sometimes seen in neonates as the result of swallowing maternal blood during delivery. In certain cases where it's important to differentiate between fetal blood and maternal blood, if an infant's stool or vomit, a test called the APT test might be requested. This test helps determine whether the blood detected comes from the infant's digestive tract or it's from the mother and has been ingested or transferred to the infant through breastfeeding or other means. Fecal analysis enzymes supplied to the gastrointestinal tract by the pancreas are essential for digesting dietary proteins, carbohydrates, and fats. Decreased production of these enzymes is associated with disorders such as chronic pancreatitis and cystic fibrosis. Analysis of the feces enzymes focuses primarily on the proteolytic enzymes trypsin, chymotrypsin, and lactase 1. So this is the fecal screening. Test examination for neutrophils. The methodology or the principle: microscopic count of neutrophils in smear stained with methylene blue gram stain or wrist stain. Interpretation: 3 per high power field indicates condition affecting intestinal wall. The next one is qualitative fecal fats, microscopic examination of direct smear stained with Sudan tree. Interpretation, 60 large orange red droplets indicates malabsorption. Microscopic examination, smear heated with acetic acid and Sudan tree. Interpretation, 100 orange red droplets measuring 6 to 75 micrometer indicates malabsorption. The guaiac fat, peroxidase activity of hemoglobin liberate oxygen from hydrogen peroxide to oxidase via reagent. Interpretation, blue color indicates gastrointestinal bleeding. The next one is the IFOBT, uses polyclonal anti-human antibodies specific for the globin portion of human hemoglobin. Positive tests and control lines indicates GI and bleeding is the interpretation. The AAP test to hemoglobin-containing emulsion determines presence of maternal or fetal blood. Interpretation, pink color indicates presence of fetal blood. Trypsin, emulsified specimen placed on X-ray paper determines ability to digest gelatin. Interpretation, inability to digest gelatin indicates lack of trypsin. For lactase 1, immunoassay using an ELISA test. Interpretation, sensitive indicator of exocrine pancreatic insufficiency. The last one is the Clini test. Addition of Clini test table to emulsified stool detects presence of reducing substances. Interpretation, reaction of 0.5 grams per deciliter reducing substances suggests carbohydrates intolerance. The last one for chemical testing of feces is the carbohydrates. Carbohydrates in the feces may be present as a result of intestinal inability to reabsorb carbohydrates as is seen in celiac disease or lack of digestive enzymes such as lactase resulting in lactose intolerance. The presence of increased carbohydrates in the stool produces osmotic diarrhea from the osmotic pressure of the unabsorbed sugar in the intestine growing in fluid and electrolytes. Fecal carbohydrates testing is most valuable in assessing cases of infant diarrhea and may accompanied by a pH determination. Lower the pH to below 5.5 in cases of carbohydrate disorders.
I am Fiona Manantan and I'll be discussing the sweat disorders as well as the analysis test. So first we have disorders of sweat include those of variations in the amount of sweat produced, right, such as hyperhidrosis or excessive sweating, hypohidrosis or diminished sweating, and bronchidrosis, or which we call the excessive or abnormal body disorder. Hyperhidrosis is a condition marked by excessive sweating surpassing the amount necessary for maintaining the body's temperature balance. The regions most frequently associated with hyperhidrosis are those where eccrine glands are concentrated, such as the axillae, palms, soles, and face. Then there are two types of hyperhidrosis. We have primary and secondary hyperhidrosis. First, the primary hyperhidrosis. This is caused by faulty nerve signals that lead to an excessive activation of eccrine sweat glands. Typically, it affects areas like the palms, soles, underarms, and sometimes the face. Now, this form of hyperhidrosis lacks a discernible medical cause and tends to have a hereditary component. Secondary hyperhidrosis results from an underlying medical condition or the usage of specific medications, including pain relievers, antidepressants, and certain drugs for diabetes and hormonal issues. Now, this type may induce widespread sweating across the entire body. Possible trigger encompasses diabetes, menopausal hot flushes, thyroid disorders, certain cancers, and various nervous system disorders or infections. The main symptom of hyperhidrosis is sweating first. So when you sweat, you may feel wetness on your skin, damp clothing, beads of fluid dripping from your cheeks or forehead. And over time, hyperhidrosis can lead to the following symptoms such as itching and inflammation when sweat irritates your skin, body odor, which occurs when bacteria on your skin mixes with sweat particles, and cracked or peeling skin on your feet. Next disorder we have is hypohidrosis. Hyperhidrosis typically manifests in a specific region of the body and can result from various factors. This condition may be triggered by a skin injury, such as stroma or burns, cuts, or scrapes can damage sweat glands in the affected area. We also have radiation. This is used to treat cancer and can damage sweat glands, leading to hypohidrosis in the treated area. Infection, such as leprosy, which is defined as a chronic bacterial infection that can damage sweat glands throughout the body. Or we have also inflammation, which inflammatory skin conditions such as eczema or psoriasis can damage sweat glands, leading to hypohidrosis in the affected area. We also have connective tissue orders such as systemic sclerosis, systemic lupus erythematosus, or Sjogren syndrome. Systemic sclerosis is an autoimmune disease, causes hardening and thickening of connective tissues throughout the body, including the skin. Hy- Therefore, hypohidrosis is a common symptom of systemic sclerosis. While systemic lupus erythematosus, this is an autoimmune disease which causes inflammation of various tissues throughout the body. And we also have Sjogren syndrome, which causes dryness of the eyes and mouth. And this can also be a symptom of hypohidrosis. Another potential cause of hypohidrosis rather is medication, which is particularly those with anticholinergic effects and nerve damage associated with diabetes, such as diabetic neuropathy, is another factor that can lead to decreased sweating. Certain syndromes present at or before birth may also be associated to this condition. In extreme cases, individuals who experience severe heat stroke may cease sweating. Last disorder, we have bromhidrosis. Bromhidrosis is a medical condition characterized by the emission of an excessive and typically unpleasant odor from the skin. Perspiration itself has no odor, but when it encounters apocrine secretion or the activity of bacteria and germs on the skin, a smell can emerge. Now, these microorganisms break down sweat, generating an unpleasant odor. Numerous factors and behaviors can lead to either foul smelling apocrine secretion or an imbalance in bacterial composition, resulting in an undesirable body odor. We have some prevalent causes of bronchidrosis. First, the insufficient hygiene. So we know that sweat itself is odorless, but when it comes into contact with bacteria on the skin, it can break down and produce odor causing compounds. Therefore, poor hygiene allows bacteria to thrive on the skin, increasing the likelihood of body odor. Second, we have obesity. Obesity is the excess body fat, which can create more folds and creases in the skin. This provides a moist environment for bacteria to grow. Now, this can lead to increased sweating and body odor, especially in areas like armpits, groin, and under the breast. Diabetes mellitus. People with diabetes have elevated blood sugar levels, which can be excreted sweat. Now, bacteria can break down the sugar in sweat, producing acidic compounds that contribute to body odor. Next, we have intertrigo. Intertrigo is a skin irritation that occurs in areas where skin rubs against skin, such as the armpits, groin, and under the breast. Now, the moist, warm environment created by this intertrigo can promote bacterial overgrowth and body odor. Trichomycosis axillaris. This is a fungal infection of the armpits. The fungus can break down sweat and produce odor-causing compounds. Next, we have erythrasma. Erythrasma. This is a bacterial condition that often occurs in the groin, armpits, and under the breast, and this produce a reddish brown patches on the skin, which can also contribute to body odor. Bacterial colonization. Certain types of bacteria, such as Staphylococcus aureus, can produce odor-causing compounds when they break down sweat. Now, these bacteria are more likely to overgrow in areas with poor hygiene or excessive sweating. We also have adverse effects of laser hair removal. This sometimes causes inflammation and bacterial overgrowth in the treated area, leading to temporary body odor. We also have presence of nasal foreign body. A nasal foreign body, such as a piece of food, can cause a foul-smelling discharge from the nose. Now, this discharge can sometimes drip down the back of the throat and be swallowed, contributing to body odor. And last, we have the consumption of diet rich in garlic or spicy ingredients. Garlic, onions, and other sulfur-containing foods can be absorbed into the bloodstream and released in sweat, causing a temporary change in body odor. Spicy foods also stimulate the production in sweat, which can increase the likelihood of body odor, especially in people who are already prone to sweating. Hyperhidrosis is also a condition characterized by excessive sweating, where people with hyperhidrosis are more likely to experience body odor due to increased amount of sweat available for bacteria to break down. Now, there are two types of bronchidrosis related to the types of sweat glands that we have. First is the apocrine bronchidrosis, which is characterized by body odor resulting breakdown from the bacterial breakdown of oily secretions. This process generates ammonia and short-chain fatty acids, contributing to development of unpleasant odors. Additionally, specific bacterial flora in the axillary region may interact with sweat, producing more acids and intensifying the odor. Next, we have eccrine bromhidrosis. Contrary to eccrine secretion, which is typically odorless, eccrine bromhidrosis, which is a less common type of bromhidrosis, can produce a bad odor. Factors contributing to eccrine bromhidrosis include dietary items like garlic or curry, as well as the consumption of alcohol, medications, and exposure to toxins. This type of hydrosis may also serve as an indicator of an underlying health condition. Now we move on to the SWOT analysis test. There are a number of different SWOT analysis tests used in the medical field, each with its own specific purpose. Now there are two of the most common SWOT analysis tests, which we have the SWOT test. The standard diagnostic procedure for cystic fibrosis is the sweat test, which detects elevated levels of sodium and chloride in the sweat of individuals with the condition. Specifically, the test measures the quantity of chloride, a component of salt in the sweat. Cystic fibrosis is a genetic disorder characterized by the accumulation of thick, sticky mucus in various organs, including the lungs and pancreas. The procedure of the sweat test, um, there are no needles in the test. So in the first part of the test, a colorless or an odorless chemical, which is called the pilocarpine, and a little electrical stimulation is applied to a small area of the arm or leg to encourage the sweat glands to produce sweat. Now, a person may feel tingling in the area or a feeling of warmth. This part of the test lasts about 5 minutes. Then the sweat is collected on a piece of filter paper or gauze or in a plastic coil. This step lasts for 30 minutes, and the collected sweat is then sent to a hospital laboratory to measure how much chloride is in the sweat, usually later the same day. The sweat test usually takes about an hour, but it may take longer. The results, chloride test result of less than 30 millimoles per liter suggests that cystic fibrosis is less likely. A result between 30 to 59 millimoles per liter does not give a clear diagnosis, therefore further testing is needed. And if the result is 60 millimoles per liter or greater, cystic fibrosis is present. Next test, we have sweat pH test. Now, this test assesses the acidity or alkalinity of sweat, providing information into hydration levels and aiding in the diagnosis of skin conditions such as dermatitis and acne. In diabetic patients, sweat pH can serve as an indicator of life-threatening conditions with elevated pH, possibly indicating prolonged periods of low blood glucose requiring medical attention. Determination of sweat pH not only reflects overall health and wellness, but also holds potential for diagnosing diseases. Normal sweat pH ranges from 4.5 to 7, facilitating the monitoring of exercise intensity and dehydration due to its association with sodium concentration. However, variations in sweat pH may occur in situations of homeostasis, dysregulation, disease, acidosis, or stress. For example, individuals with cystic fibrosis may exhibit higher sweat pH up to pH 9, making sweat pH a potential indicator of metabolic alkalosis.
So that should conclude our discussion on feces and sweat. Thank you for listening.